Hey, Elizabeth, I think let's go ahead and introduce Dr. Kerns.
Okay, perfect. Thank you everyone for coming today to our seminar. Happy to invite Dr. L. Kerns to present today. She is the Director of Research Informatics for CHRI, and she also serves as a data scientist for Children's Nebraska Care Transformation Division. And she also is the Director of the Biomedical Informatics Core for the Great Plains IDeA CTR, and serves as a Deputy Director for our Informatics Service Corps Ready here at UNMC. She's very interested in leveraging technology to augment health decision making and optimizing efficiency of research by making better use of existing data sources. And outside of work, Elle loves to travel the world and being active outside. And today she is doing a presentation called Standardizing Pathway Implementation Evaluation. Whenever you're ready.
Sorry, shared and lost my audio controls there, guys. All right, so this presentation is going to be about our local attempts to standardize how our pathway implementation outcomes were evaluated here at Children's Nebraska. So some of you may be wondering, what are pathways? They are multidisciplinary, task-oriented, and time sequence plans of care. What they do is they take national practice guidelines and the latest literature, and they create local teams take that, plus local practices, and create algorithms like pictured here for how to treat patients meeting certain inclusion-exclusion criteria. That doesn't mean that every patient who meets those inclusion-exclusion criteria is going to follow these exact steps every single time. But this is what is recommended for the majority of patients based both on local practices and consensus, as well as what is out there in the literature and national guidelines. So hospitals have been trying to implement these pathways for a really long time. There has always been struggles with how to disseminate your pathways, how to track whether people are actually using them, and then how to figure out whether they actually work. Now, there are standard methods of evaluating where they work that people publish on. A lot of quality improvement work is about pathways and their metrics and kind of analyzing. But doing it at scale for tons and tons of pathways across the organization is a bit of a struggle. You can't really have your own statistician and your own separate pull out and analysis for every single one. It's just not a sustainable thing. So what we were doing here at Children's Nebraska locally is we disseminated the pathways through educations and rounds and at department meetings. They were posted to Children's Nebraska's website. They also, to help people follow the pathways, implemented order sets that gave which were a bundle of the typical orders that you should make for a patient who meets the inclusion criteria pathway. We also did a few things like BPAs and other traditional forms of clinical decision support to recommend those order sets. And then as far as tracking how they were used, we also used the pretty standard method of seeing how many people use the order sets. Now, does that tell you that they looked at the algorithm or the guideline of like how to manage the patient that I showed on the prior screen? No, it doesn't. It just tells you whether or not they used that bundle of orders. And then whether or not they use that doesn't necessarily is a good indication that they followed the pathway, but you can actually follow the pathway and not use the order set. So it has that limitation there. Another thing we tried using is since all the pathways material were posted to Children's Nebraska's webpage. We used web analytics to look at like who was using those, who was viewing those pages and how often. Not who was an individual, but at least like whether it was internal or external traffic to the website and exactly what they were clicking on. Again, limitation because you could just download them from the website and refer to them later. Having people go to an external website is a not super great way to get something used every time in practice. And so those are some of the limitations there. And then as far as like tracking whether the pathways worked, most of the time this was done by having report writers, our local report writing team. They would write queries that met the inclusion-exclusion criteria, and they'd kind of give raw data reports in Excel format every month of like, this was the monthly values on the metrics for the pathways. Which is good because it's some data and you kind of have a kind of point in time of like this month, this is how we're doing, but not so great for trending over time, which is really how you're supposed to be evaluating these. And so that was the limitation there. So we tried to tackle the problems that we were having in two ways. For dissemination and usage tracking, we looked at vendors for EHR embedded pathways. Not going to talk about here that in this presentation. This presentation is about how we standardize evaluation tracking. And how we did that is we were already moving as an organization towards dashboarding our data requests, especially for ongoing reporting needs. And we decided to use that dashboarding software that we had, Power BI, to create refresher reports of pathway metrics. So now I'm going to talk through the process of setting up these pathway dashboards and the problems we ran into along the way. So the first problem is communication, and that's the communication between the clinical people involved in the pathways and the technical people who are building these dashboards. They don't always speak the same language. When a clinician says a patient with asthma, it makes sense to all their fellow clinicians, but what does that mean actually for the data person? And so there was a lot of assumptions and it's a lot of like misunderstandings going between teams. So one of the first things we did is we tried to come up with a standard handoff document for making the path metrics, not only the metrics, but the inclusion and exclusion criteria for the pathways clear and computable. So that means explicitly listing their inclusion criteria, their exclusion criteria, what the numerator of the metric is, what the denominator of the metric was. And then we gave tips and tricks of like, if possible, use these more standardized things like ICD codes and other discrete fields to define each of these criteria over things that are less discrete, such as a note templates, because these are intended to run automatically. So if you have to manually review all the charts every time because you're trying to base your pathway metrics or inclusion exclusion off of non-discrete data, it's not going to work. That did pose limitations of what could be used as a metric, but it's a compromise that we had to make. Also, big emphasis on specifying a numerator denominator, making sure if you have a time-based metric, you say exactly what timestamp you want that time-based metric to start with and what timestamp you want that pathway metric to end with. That first example there, bad example. Length of stay of patients in the denominators. What do you mean by length of stay? A lot of people think that's pretty standard, but you could mean time from triage to discharge, time from triage to admission to the inpatient floor. You could mean time from showing up to discharge. And you may be clear among yourselves as clinicians what you mean, but your report writer's not going to know unless you explicitly tell them this timestamp to this timestamp. And then we kind of set some criteria for obtaining their baseline data. And that we allowed that to vary based on how many cases are typically seen per month for a given type of pathway, right? So asthma patients are super common. Stroke among kids, not as common. And so they needed a little bit more cycles, a little bit more months of data to really truly establish a baseline. So an example of what this handoff kind of document looks like, you have your pathway name as how you want it named. What is the update frequency? So what is your cycle length? Is it a month, or is this one of those more rare conditions and so it needs to be quarter? Or is it even so super rare that you have to do it on an annual basis because you're only getting 5 cases a year? What is your baseline time frame? What are your inclusion criteria with the codes that they correspond to? Exclusion criteria. Your SMART metric with a given goal of this, improve it by this amount by a specific date. And then you can see that this numerator not only says explicitly this order set, but even gives the order set ID number, and that the denominator is everybody who meets that inclusion exclusion criteria listed above. Also gave a little bit of a few rules of, so with metrics, with pathways, there's usually an outcome, like a patient level outcome, like how did this impact the patient? Process metrics, like what did we change in our workflow that we think it indirectly impacts outcome metrics, and then balancing metrics where it's like, we don't think that this pathway is going to affect this. We don't want it to affect this, but we're making sure that nothing we do is causing this adverse outcome. And we set rules of only 5 metrics, right? Because this is a bandwidth thing. If we want every pathway to have a dashboard, we can't have 1 million metrics per pathway. And it's also poor practice, right? If you're trying to really impact something, looking at 20 things, you can't really narrow down and discreetly make sure you're having an impact. So the other problem that we ran into is like, okay, we can go and we can put this as a line chart and a dashboard, but we really want them to be control charts. We want them to have control limits, and we want them to shift when special cause variation is detected, because that's the gold standard for pathway metric evaluation. And we want that to happen automatically. And we wanted to do it without paying for an additional thing that we weren't already paying for. So we found a free Power BI visual that does a lot of that. It's got this control chart format. It auto adjusts the center line based on the Shewhart rules for special cause variation. You can put a goal line, and it auto calculates the center line and the control limits. The limitation of this particular solution that we landed on is that you can't add sample sizes to the cycles, which is typically wanted or included in a run chart for a pathway. And you can't add annotations like this is when we did this intervention. And then there's limited amount of customization that you can do with your axes. Like it would be ideal if it was saying 0 to 100% there, because that's what it is. But it's got to be 0 to 100. We can't get the little % symbol in there. That's just a limitation of this free widget that we're making use of. So some things that we did to get around those limitations, but still kind of get people the data that they needed, is we added a corresponding annotatable line chart with a count of the total number of encounters meeting pathway inclusion exclusion criteria on the same page as the run charts. So you can see here, we were able to like put lines when different interventions were implemented, and then we display that to the side or above the run chart so it kind of lines up. So yes, it's not on the same graph, but you can kind of see, you know, in November, December, there were way more encounters, and that lines up when this metric got all screwy, right? And so not perfect, but it still gets out a lot of those information needs. The other thing is, although the goal is to validate this data before we get it all into the dashboard and have it running, there's always a need to like drill down and say, okay, what happened this month? Why did this go out this way? Is there just one weird patient? And so we added drill down matrix. So you can kind of, you look at like the actual ends for the numerators and denominators of a given metric on the page. And then on a separate page, you, for viewable by only leadership. So it says leadership view there. This is important because our non-drill down to PHI or provider specific information version of all of these pathway dashboards, we intended them to be public to the organization. We wanted this information out there. Children's Nebraska wide, this is how we're doing on these pathways. That was just super important. So we created leadership views where they can actually drill down and be like, okay, this is the actual values for the things that go into the metrics for each individual encounter that's qualifying for this pathway, and see if there's some erroneous value, some erroneous encounter. Maybe we thought the calculation was good, but oh, hey, it doesn't work in this particular case. So this is what the final template looks like. So you can see the encounter count lines up with the run charts. You've got the little drill down on the right-hand corner. You've got some things that are important. This is the heated high flow pathway. And what was important for them to be able to partition out by was whether these patients ever were in the ED and whether they were ever in the PICU. So those are some relevant filters that they can select. Anybody who has any value, or just yes to the ED, or just yes to the PICU. And then they can also kind of change their discharge date, time range, in case they wanted to look at a different set of time. So cool, it's all out there and we can build based on that. We've got a way to hand off and make those. And then when the people who were involved in building the pathways and giving off those metric definitions, maybe they know they have those memorized, probably not, but also we're making these public. So across the organization, not every individual in the organization is going to know exactly how we define those metrics. So we posted that as part of the dashboard. There is a page on every dashboard that says how each metric that dashboard shows was defined, and all the way down to the IDs of the orders, and the codes that went to the inclusion and exclusion criteria. So it's very clear to anybody looking at this, this is what this means. And you know, if they can't look at it and be like, well, I know from my other thing that I was looking at, that admissions were this high, and it's like, well, it's defined differently than it was in this. You can kind of validate that. Got your definition right here. So then how do we get this out to people? How do we show people this data so they can act on it? Beyond just the people who are leading the pathways. We added it to our clinical effectiveness homepage. That is the team, department, division. I don't know the best way to refer to them. But that's the group who works on these pathways, who sets all the standards, who makes all the toolkits. They have a homepage on Children's Nebraska's webpage, and we link out to the dashboard right from there. We added a link to the given, for each algorithm for a pathway, there's a link out to the corresponding dashboard. And then there's been lots of kudos and report outs at related department divisions, rounds, and meetings to be like, hey, we're doing really well on our DK pathway, ED. You really helped with this part of it. Great job. And then the clinical effectiveness team makes sure that the pathway leadership is for the leadership for a given pathway is reviewing their pathway dashboards at least once a month, reevaluating what they're not once a month, sorry, once a quarter. Once a month would be a little extreme. Once a quarter, reevaluating what their goal lines are whether they need to make any new interventions because one of their metrics just isn't budging, or any of those kinds of adjustments that they may have to make. It's also where they can drill down and be like, why is this metric looking funky? So we build all this. That's great. A lot of times, I don't know if you're a data person or report birding person or a statistician, you feel like you make a bunch of stuff and then nobody ever looks at it. So are people looking at this? Well, this is the viewership of our Pathways app, which has all of our pathway dashboards in it, in the last month. So it's been viewed 247 times in the last month. You can kind of see that some pathways are looked at more than others. 5 of them seem to have not been looked at. So maybe that wasn't their month or they're just not up for review. You can see a lot of report writers and clinical effectiveness team members in that part that I probably should have blanked out the names on, but we're okay, including my own name. So we're looking at it a lot, but you can also see that it's not just us looking at our own stuff. Other people are indeed looking at this. So then, are they working? So there's lots of papers published that show that audited feedback works. So theoretically, this would work. Can I prove to you that a dashboard made the difference in any of these metrics that clearly had changes? No, I cannot, because when they set up their baseline and they set up their metrics, they also pick interventions to target the metrics. But you could argue that they wouldn't know which metrics to target unless they had seen the data charted out. You can decide for yourself whether you think this is what made the actual difference. There's no way to statistically prove it, but here's a very cherry-picked set of different pathways and their metrics that have had success since we've had these dashboards come out. So like our key to high flow pathway, the goal is to get the median time that people are on high flow, kids that are on high flow down, we're down below the goal of 30 hours, which is pretty good. Having been on a national project that was trying to get that down, that's pretty good nationally. Our constipation pathway really eliminated those unnecessary x-ray orders real quick. So that's a big success story there. The SSCI pathway wanted to improve the rate in which patients were prescribed the correct appropriate first line therapy immediately, like our as the first thing that they're given, and that's gone up. And then in our asthma pathway, we've reduced the median time in minutes from the patient getting triage to them getting a steroid. So all that being said, I left a lot of time for questions. I'm happy to take questions or show you more about any of the dashboards, pathways, or what we did. I'm gonna stop share so I can see chat faces. Sounds like I left too much time for questions. Could have fit in the whole thing about what we did to make sure people are actually using them.
I have a question,
Sure.
and I may have missed it, but the green dots that were on the pathway, is that like the goal? What
Yep.
on that last screen?
Yep, those are
Okay.
so those were the given goal for the particular pathway. So those are set at the time in which we get a baseline. And so they look at it, they look at like where they would want to be based on the literature, but also like where could they reasonably get within the next 6 months to a year? And they set those goals there.
Can we look at that last screen one more time?
Yep. I don't know why I unshared. That was just not good. Okay.
So like the SSTI pathway,
Yep.
It seems like it's slower than the green line. And I was just curious, like what, in that case, what do you do to try and increase use or?
Yeah, so probably some direction orientation here of like the way that we want these things to go. So for meeting hours on high flow, we want that down. X-rays, we want down. Time from triage to steroid, we want down. Patients prescribed first line inclusion antibiotics, we want up. So any green line or higher is great. You're right, that's the one on here that's not meeting its goal. And so there are a variety of things that these groups try in that case. So some of them is suggesting the appropriate antibiotic order based on the chief complaint entered into the ED, if it's an ED oriented pathway or the diagnosis getting added to the problem list. If it's inpatient, if one of the other things, so this is skin and soft tissue infections is what SSTI stands for. Another thing they kind of look at is if you can make orders for a particular indication, and if you're making an antibiotic order for a given indication, that we don't recommend that antibiotic is first line. They can get a kind of a BPA to pop up at that point. But beyond all of that, what we're trying to do with all of our pathways is that other solution that I didn't think I'd have time to talk about, which is how to get people to use the pathway and track whether they're actually using that. And so we've taken our algorithms and we purchased a software for embedding those within the EHR themselves. And it kind of pops up when anything's kind of entered about a patient to be like, hey, you should be really using this. And then it drops them right into the pathway where they can see the decision that like, oh, hey, these are the antibiotics we recommend trying first for SSTI patients.
Awesome, thanks.
Yep.
There is a question in the chat.
Yeah, I was just looking at that. When measures such as length of stay are different across pathways, how do you make sure that is communicated? So that's one of the things that we are trying by making sure that every pathway has that definition tabs, that has that summary tab that says for this, the length of stay metric for this pathway is from this time to this time. It's pretty standard, like it's typically pretty standard what people want. If it's an ED pathway, the start and stop times are pretty set, and the inpatient, they're pretty set. But there are some differences sometimes, and that's why we try to make sure that the definition for a given metric is on the dashboard and available right there. So we haven't done a lot of that yet. The question is, are patients following multiple pathways intentionally and like comparing outcomes? So a lot of these pathways branch. So like one for febrile infants, there's different things recommended based on what age group you're in. But we haven't tried to we haven't done any A/B testing where it's like, okay, hey, we'll put part of the patients on the pathway going this way, part of them going this way. It's a little bit tricky from the QI research designation, like how to accomplish that. But it's not something that we've thought about doing. What does the y-axis mean? So that is the percent of, unless it's a time-based metric, like that bottom right corner, the y-axis on that one is minutes, and the top left, the y-axis on that one is hours. The other two are percent of patients meeting the denominator criteria, which is usually just meeting the pathway, but sometimes there's special caveats for a metric, who had the right thing done. So in the upper right, it's the percent of patients who should be on the constipation pathway based on our inclusion-exclusion criteria who get an X-ray ordered, which was way too many. And now we're down to 20%. Way better. There's a pretty good theme with pediatrics, no chest X-rays. That's a pretty common metric. Any other thoughts, questions? Who initiates the use of new pathways? Depression screening for parents. So that's that clinical effectiveness, the people in charge of what pathways go up, and what we're focusing on is our clinical effectiveness team. Anybody can submit to them a proposal for a pathway. They have to fill out this thing called a charter that explains like what is the literature behind why they're trying to do this pathway, what are they generally thinking about doing, their initial inclusion-exclusion criteria. Then the clinical effectiveness team gets them paired up with the report writers, help them get their baseline data, and then we decide among, as a steering committee, I'm on the pathway steering committee, like, is this pathway clean enough? Is it prioritized to go out next? Is everything clear? Should we let it go live? So it's a very committee-based module for that, and there's been a lot of investment on that, so big kudos to Children's for prioritizing it and making sure there's a big team in place to make these pathways happen. It's a lot of work. I built like 5 of these dashboards. Okay, there's a template, hand it out to the report writer now. And that's just the building that part, much less all the literature and the algorithms. It's a big undertaking. I don't know, and this is anybody who works at Nebraska Medicine can let know differently. I don't know if Nebraska Medicine has a similar process. Pathways seem to be a very peds coin thing. They're bigger with peds than they are with, it seemed to be at adult hospitals.
Elle, do you think like adult populations could benefit from these pathways as well?
Yeah, I don't see why not. I can't think of a reason why not. I'm sure there are evidence-based guidelines about how to treat adults based on a particular condition. And like I said, I don't know that Nebraska Medicine isn't doing that, and maybe they're just not calling it pathways. I don't know it, but the pathways is the big term among pediatrics. And a lot of emphasis is put on this by AAP. They put out new guidelines every year for this condition. This is what the national consensus to be done is. And then they do national projects to like try to get people using that latest guideline. So maybe that's why they're big in peds, is that kind of organizational momentum. Not all pathways are discipline specific, and our clinical effectiveness team has a requirement when you submit your charter that every discipline that is a major part of taking care of a kid with a particular condition is represented in the group working on the pathway. If there's some leader, you know, like if it's a pathway that crosses from ED to inpatient, you have to have a hospitalist and you have to have an ED attending. You can't just be like, we're inpatient, we're just implementing this on you, ED. Good luck with that. I can't do it. So like one of the SSTI pathway has infectious disease discipline on their on the leadership committee, and one of their metrics is actually referral to ID in a timely manner. Any other questions about how we did these dashboards or how pathways work overall?
I don't see any more chats or any more hands up. Elle, this was great. Thank you very much from the Professional Development Corps. This is very stimulating talk, and it looks like we had a good turnout. So thank you.
Yeah, appreciate it. Thanks. Happy to take any questions later if somebody thinks of something. I'm sure my email's on the.
Or email you. Yeah.
Yep. Sounds good. Thanks.